So when we talk about the class Research 2 in our program, we kind of are talking about changing the title of that class in future so that it will no longer be called Research 2. The title of the class will become something like Personal Practice Assessment. So that, for one thing, that's less scary because it doesn't have the word research anymore. And the fact that it does have the word personal in it, this is more interesting because, hey, if it's personal, then it must have something to do with me. And therefore, maybe I can look forward to something that actually has some relevance to me as a soon-to-be master's level practitioner. So when we say personal practice assessment, I'll just call that for now PPA, personal practice assessment. And we could describe that. It's primarily about, not exclusively about, but primarily what it's about is single system designs. So that's a term that we can use to talk about what the content area of what this class is about. A synonym for that would be single case designs, although not every single system design is only about one case, as we'll see. But for the most part, those two terms are often used basically synonymously or interchangeably. Another term that you'll see in the literature is N of 1 research. Now, in research speak, when research methodologists and scholars and stuff are getting together in groups and talking among themselves, and they use the word or the syllable, the letter really, N, what they're referring to is number. N means number. So when research methodologists and stuff are getting together and talking among themselves, they'll be talking, oh, I'm doing this study, and the other one will challenge this one and say, what's your N? Which means, what's the size of the study population that you hope to be able to amass? And when we're doing research that has to do with statistical calculation, for the most part, the larger the N, the more powerful the math is going to be, that you can have faith that the outcome was actually, if there's a difference, as you remember from your Research 1 class, in group research design, let's just say I was doing a group research design where I'm going to be studying a group of potential clients in, let's say, the treatment of depression. And so from here on over, this group is going to be the participants in some therapy. And this group are going to be just simply on a waiting list. And so I'm going to test out whether I would have to have both groups be people who are depressed, of course. And then I would be wanting to test out if I give therapy to this group and then calculate the average amount of change in an indicator of depression. And then I don't give therapy to this group, but nevertheless there's any change at all. I can then calculate how much of that change is probably attributable to the effect of my intervention rather than being attributable to simply the passage of time. And so the larger the number, the N, the more statistical power. If I'm claiming that I got some kind of a significant effect, if the N is larger, for the most part, it probably means that I have more statistical power to say that it was my intervention that made the difference rather than simply the passage of time. But in this case, we've got an N of 1. We're trying to get meaning. We're trying to learn something that's relevant and of practical, applied, clinical usefulness by only studying one case at a time. And so we can't use numerical clout to decide whether or not that's going to turn out to be significant or not, because we have a very tiny N. We have an N of 1. But you will see that expression in the literature, N of 1. So how this all came to be, this study, how this study came to be was that when one is a doctoral candidate, one has to write a dissertation. And this is like an enormous term paper. It's a huge term paper. This is my doctoral dissertation in bound form. You see that it's 300 and some pages. Now, if I ever have a student who I assign a term paper with a page limit of 15 pages, and they go, oh my God, 15 pages, you know, it's all relative. So this is an enormous term paper. And the point of doing a dissertation is, you know, there are several reasons for doing it. One is because you need to be able to demonstrate that you have the staying power to stick it out in a doctoral program until the thing is finished. So to some extent, it's a measure of your capacity for delay of gratification, which in turn is to some degree related to the construct that some of us have maybe have encountered, like in a HIPSI course or something, the notion of emotional intelligence. And one of the sub-features of emotional intelligence is the capacity for delay of gratification. So this probably means that you're going to be able to tough it out in the world of work in an academic environment. The other thing is that you have to be able to prove that you can conduct original research. So here's proof. I did original research. It was finished. Results happened. It's a published thing, and I now have the bona fides to be able to come here and tell you something about the conduct of research because I've proven that I can do it. So this is part of what one has to accomplish in a doctoral program. Well, it so happens that my doctoral research was single system research, which is actually an unusual thing. A lot of doctoral programs will not allow you to do single system research as a form of justification for the award of the doctoral degree. But in my particular case, I had actually planned to do a group design. The plan for that actually didn't happen. The plan for that was interfered with by factors, some of which a couple of you here have heard about in the past. I've mentioned something about that. Anyway, my group design research didn't happen. And so I redesigned my doctoral research prospectus to conform with single system research, went back to my doctoral committee with a proposal asking to be allowed to do it this way, was granted permission, and that's how that came to be. Okay, so the title of the study then was Using Guided Dialogue in the Treatment of Depression in Women. So that's what I'm attempting to accomplish in my research. Study the use of a therapy method. In this case, it was something that I basically invented for the purpose of this study. I called it guided dialogue. So next thing we look at is what are some of the influences that factor in when you're getting ready as a scholar or a practitioner, either one. What could some of the influences be that would factor into the process of planning for a research study? Well, it's possible that the research study might evolve out of previous work that you personally have done in the field. In this case, I had been in practice for about 15 years when this all began. And the great preponderance of the work that I did in direct practice to that point was the treatment of depression in women. So I had some expertise in that field. It certainly made sense to me to take up that study again, that question again, and make that into my research topic for my doctoral research. Another possibility is the doability of it. Well, I won't go into the whole story, but it turned out that the group research design that I mentioned a minute ago that I had originally proposed to do turned out not to be doable for reasons, part of which were economic, part of which had to do with referral sources, part of which had to do with departmental politics in the academic program with which I was associated. That design turned out not to be doable. So I went back to the table and redesigned my research to make it more highly doable, and that's what resulted in this deal. It also is possible that if you were doing research that it will originate from direct practice experience that you have. Now, when you do your N of 1 studies in this class, it's going to evolve directly out of the things that you're doing in your field placement. So it will mesh in that sense very nicely. It's also possible that the theoretical background behind an area of inquiry will very heavily influence the design of a research study. And in this case, it influenced it a very great deal. So we're talking about the topic area of depression in women. And so we look at the theoretical background. Now, it so happens that this thing, as you see, it's thick, it's a book, it's bound. The last probably about 30 pages of it is all the reference section. So you can see that a great deal of background research went into fleshing out and rounding out my academic understanding of the background behind the subject of depression in women. And some of these findings emerged from that background research. It's all got to go in a dissertation. You can't defend your dissertation unless you pretty much prove that you know chapter and verse, you know, the area of inquiry that you did research on backwards and forwards. Okay, so it turns out that when we look at the epidemiology of depression, that depression is the most common form of mental or emotional illness that is seen in clinic settings. More patients go to treatment for cases of depression, problems with depression, than any other single reason. Therefore, it's a good thing for our field to know a lot about. This supports the need for a study like this because depression is, as I've mentioned to some of you in the psychopathology class, depression is the common cold of mental illness, and so there's a lot of work to be done. It also is the second most common form of mental and emotional illness in the whole world, the most common problem being anxiety, although people who are anxious go to treatment with far less frequency than people who are depressed. They just are more likely to turn out and seek help for depression rather than anxiety. And it's twice as common among women as men, and that ratio holds true in our country. It pretty much holds true all around the world. Okay, so all of this supports the idea of this particular piece of research being done because the need is so huge. It also supports the idea of the population, the study population, being limited to women because they're the ones who suffer with this illness the most amount. So all of this supports the basis for which, upon which this study is being proposed to be done in the first place. Other facts about it are that it's estimated that it costs our country, in terms of lost productivity, approximately $43 billion a year in treatment and also lost work time for people who are debilitated by depression, and therefore they can't work or they can't work effectively. So all of these are things which support a claim that one might make that to do this piece of research is a valid thing and that it, that there's a reason for it to happen. And also the fact that in our country, the statistics for rates of suicide, unfortunately, are not on the decline. Rates of completed suicide in our country are on the increase. So that whatever it is that we know about depression and how to treat it, we may know quite a lot, but obviously we could know more. We can always improve on the way that we offer treatment for this illness. Okay, so also when it comes to background, another factor is what are the psychosocial correlates? In other words, if a person has depression, what other variables that control or influence their life are also relevant, also play into the ecological or systemic picture for that person in terms of person in environment. So of course there are biologic factors. People who are depressed have limbic imbalance. They essentially have neurotransmitter depletion. They have what the average person in the street would call a chemical imbalance. So is there anything that we could do about that? Why, yes, we could give them some medication, and often we do. But that's beyond my purview. I'm not going to study that because I'm not a psychiatrist, I'm not a medical person, I cannot prescribe drugs. So maybe we want to know which drugs work better, but I don't want to know that in terms of planning my research because I can't, do a study that's on that subject anyway. There also are cognitive disturbances, cognitive distortions. And that actually is a symptom. It's in DSM. Cognitive distortions is a symptom of depression. So that matters a very great deal. The fact that people who are depressed don't think clearly. They have a tendency to look on the dark and gloomy side of everything. They overgeneralize. They look on the dark and gloomy side of many, many features of their life context that did not seem so hopeless and dark and gloomy before they got depressed. So the fact that they have cognitive disturbances is very relevant in the illness. Now, is that a thing which I can do something about in my research? Yeah, very much. I can help them with treatment to alleviate or, as we say, cognitively restructure some of the cognitive disturbances that they brought to me when they began treatment. So that's a factor that I can factor into the design of my research. They also have low self-esteem. That also is a diagnostic criterion for depression. Feelings of excessive guilt and worthlessness. That is, that laundry list of 9 symptoms of depression that we studied. So feelings of low self-worth. Now maybe I'll just invent a patient. Let's just call her Gloria. Before she got depressed, Gloria had a reasonably positive self-concept, maybe. Or if it was on the borderline, at least it wasn't that terribly painful for her. But when she becomes depressed, her self-concept spirals down to a new low for her. So the fact that her self-concept is impacted downward by depression is very much a factor. Is that something that I can do anything about in the course of my piece of research? Maybe so. Maybe I can address that in the treatment plan. So I put that on the list of things to try to impact on, try to make a difference with, and to measure. There also is a clear link, a clear correlation between people who are depressed and a downward pressure on their general well-being. They don't feel well. Oftentimes they have immune disorders too. Their personal immune system is not functioning well. They're much more susceptible to a whole host of biomedical diseases because their immune system is depressed along with their brain and along with their limbic system. So there's a suppressant effect of having depression that takes place and impacts a person's general biomedical well-being. Also, their general feeling about their life that their life is, going well. But the single most important psychosocial correlate of depression is that, let's just say, going back to the idea of a group design, let's just say that I split this class in half, like I was talking about a minute ago, and let's just say, for argument's sake, that everybody in this room is at risk of developing major depression. You've got a tremendous amount of stress on you, life crisis. Your mood is sort of slowly sinking. But let's just say that from here on over, all of these people have somebody in their life who's like a best friend to them, a confidant, somebody to whom they can go and confide, somebody to whom they can self-disclose, somebody that they can kind of share their burden, and the other person will pick up half of it and help them with that and provide support. On the other hand, these poor folks over here, I'm sorry, I'm picking on you. You all are at risk of becoming majorly depressed, but you're all very alone in the world. You have almost no really close friends that you can trust and confide in. Sorry about that. Obviously, I'm making this up. Therefore, your risk of being the ones who actually develop the major depression is hugely greater than your risk. That's the single most important factor that separates people out into those who are at a higher level of risk for depression as opposed to those who are not so much at risk. So that's a big deal. And so we study this from the perspective of the underlying theory. There's a social work theory called the membership perspective. I don't think we teach it in our program. It was written about by a professor at Virginia Commonwealth University named Hans Falk, but he's written a textbook on the subject of the membership perspective in social work. And basically what he says is that it's almost as simple as to say that people who are symptomatic of problems with holistic emotional well-being have some kind of tension in their membership in the human community. You know, that people who are sad or in a bad place in their life, something has happened that has negatively impacted their sense of belonging in the human community. And that's perhaps a little bit of an oversimplification, but that's what Dr. Falk said, and he calls it the membership perspective. So these are people who lack emotional intimacy in their lives. The same thing can be found to be true in self and relation theory, which was offered to us by, some of you may have heard the name Carol Gilligan, and she was a writer who did research on this topic, and she worked at Harvard, and she was one of the original people who said that women in particular experience relationships as of central core meaningfulness in their lives in a way that isn't exactly the same way for men. And that was called self and relation theory. And it also supports the idea that having a deficit of emotional intimacy in your life is a high risk factor for depression, and also a factor that's going to impact and negatively put downward pressure on the likelihood that a person will recover appropriately if they did become depressed. And then also attachment theory. You know, we know that the work of John Bowlby, I'm sure all of us have heard attachment theory, that people who developmentally come through the early days of their life with secure attachments have better mental health outcomes on the whole than people who don't. So this concept of intimacy being very integrally involved and important, both as a protective factor in the presence of intimacy and as a risk factor in the absence of intimacy, you know, is very well documented in our field. Okay, so then these are some of the things that co-vary with depression. So then we take a look at how has depression been treated over the years. Well, starting with Freud, he invented psychodynamic theory, and his form of treatment that he offered to the world essentially was psychoanalysis. And I'm going to pick on psychoanalysis here for a minute, and I'm going to say some things about it that are an oversimplification, but not entirely untrue. Basically, back in the days when psychoanalysis was pretty much the only form of psychotherapy that was out there, a patient who was being offered psychoanalysis would come to his therapist's office 3 times a week for 50 minutes at a time. And the patient would lie down on a sofa kind of a thing, like a Victorian-era swoon sofa-looking thing. In French, that piece of furniture is referred to as a récamier, but whatever. Anyway, so he would stretch out on this, I call it the swoon sofa. Oh, hand me my salts, you know, and the Victorian lady faints on the swoon sofa. Anyway, you know, I'm making that up also. But anyway, so he would stretch out on the swoon sofa and just begin free associating. Meanwhile, the therapist is behind a screen, not visible to the patient and not saying very much at all. The patient is just lying there saying things like, "Oh, doc, I had such a bad week. I got into an argument with my father." And the patient from behind the screen says, "Sie Father?" Sometimes we look to the father, I'm making that up also. Anyway, so he wasn't very active. The therapist was not very active in the process of treatment. And sometimes this analysis could go on for 3 years or 5 years at a time. Well, we've learned since then that this was not a very efficient way to do therapy, that there are ways to speed it up and ways that are much more relational and equally effective. So we basically are not going to treat our depression with psychodynamic theory. It's not well supported for the present use. Okay, so ditch that. Now, psychopharmacology has been shown to be equally effective as a way to treat depression in comparison with therapy. Equally effective, but not better. So, and that's, again, not something that I can do. Therefore, I'm not going to get into that. And it turns out that actually I'm doing this piece of research in an outpatient mental health clinic. And one of the reasons that I was able, in terms of that doability factor that I mentioned, one of the reasons that I was able to do this piece of research was that the psychiatrist who was the medical director of this center had a bias. He was very much dissimilar to the way that psychiatrists are today. Most psychiatrists today, if anything, tend to be inclined toward pill pushing. They want the patient to begin taking some kind of a chemical compound, and sometimes that's all they offer. So a lot of mental health patients today are on medications and they're not actually getting therapy. Well, this particular medical director of this center was old-fashioned. He always preferred for the patient to recover through a talking cure rather than therapy. He was extremely reluctant to even offer to a client psychoactive medication if he thought there was any way to fix the problem without it. So these are all the patients that are taking place in this research are people who are not on any medication at all. That's kind of rare. It's hard to find that number of cases of people who are depressed but not on medication. But that made it possible for me to claim that if any change happened and the people got better from their depression, that it was not interfered with, it was not a confounding factor of whether it was my talking therapy that made the difference or whether it was their drugs, because they were not on medication. And so cognitive therapy has been tried for decades, 50 years or so. Cognitive therapy has pretty much been the treatment of choice for major depression. Study after study has kind of proven that that's likely true in a great many cases. So that to me is promising. Do I want to incorporate the tools and the techniques of cognitive therapy into my study? Yes, I do, because I'd be, remiss not to. So part of my research design is going to incorporate the tools and the techniques of cognitive therapy. But my background research also indicated to me that the prototypical demographic where depression peaks in American society, in other words, the largest single population group that is subject to depression, in America at least, are single or married women between the ages of 25 and 44. Depression, that particular group, was more at risk for becoming depressed than any other group. Now you would think that if intimacy mattered, that women who were not married would be at higher risk of depression. But what tends to happen a lot of times is that you'll find mention of this in the psychosocial literature, but in our country, perhaps less so. This research was actually done 20 years ago. Some of what I'm talking about is still statistically exactly valid. There have been social changes since then. So to some extent, some of the background may have shifted a little bit in terms of popular culture. But still, to some extent, there is remaining evidence that for women in America, the institution of marriage is not necessarily as socially, psychosocially supportive as we would hope that it were. A lot of women marry and they hope that their husband is going to be their best friend. And they put all of their time and all of their loyalty into married life and being a mother. Meanwhile, hubby goes to the golf course, he goes to the bar, he's got buds, he's got male friends, or he just is not as relationally oriented as she is. So now personally, I'm just going to tell you a quick thing. I don't mean it to get too far off base. I was once divorced. I was in a marriage which led to divorce, and it was remarkable to me that after the divorce happened, for me to realize how much less lonely I was as a single woman than I had been while married to an incompatible person. And I began to try to kind of figure out, why is that so? And I realized that for me at least, if you're with somebody and you're still lonely, that's really bad. Whereas if you're not with somebody and you feel a little lonely, you don't have to take it so personal, because the reason why you're lonely is because there's nobody here, you know. Anyway, it turns out that that's true in a lot of American marriages, that they lack, or at that time they did. To whatever extent marriage has, the quality of American marriages has improved, I don't know. But our divorce rate has not improved. So I think it's possible that there could still be an intimacy gap in the institution of marriage, particularly for women. A striking finding that I discovered when I was doing this research is that married women between the ages of 25 and 44, with a single spike in the population of people at risk for depression, in men, it was recently divorced men. They became depressed if they weren't in the marriage, whereas women were depressed if they were in their marriage. What does that tell you? Well, it may tell you that enhancing the quality of the marriage might be a good thing to do to help that woman with her depression. So part of my plan in doing this study was to see whether there could be relationship enhancement as a component that would be wrapped up into and included in the treatment plan. And so now we have the idea that I'm going to now test whether doing cognitive therapy with a group of women one at a time without doing any collateral therapy is better, or is it better for me to do combined therapy where part of it is cognitive and part of it is a pairs relationship enhancement modality. And I'm going to wrap both of those components into the treatment plan. So this is now my study. I'm going to compare cognitive therapy freestanding with cognitive therapy combined with a relationship enhancement modality and see which is better. Okay, so individual and pairs combined. Now, so I have to invent this therapy model because I'm in a doctoral program and your doctoral committee says you have to reinvent the wheel. Why do I have to? Oh, it's because you're a doctoral student. Oh, okay. So I did a lot of research into the kinds of marital forms of treatment for depression and the kinds and forms of relationship enhancement treatments that I might be able to pull ideas from and incorporate them into my treatment model, which I'm now calling guided dialogue. So guided dialogue becomes a dyadic treatment sequence designed to increase emotional intimacy between a depressed woman and a chosen significant other. That's my goal. And so I worked out for there to be 6 two-hour sessions utilized of this guided dialogue, utilized with homework sessions in between. And guided dialogue, the structure of it, the model of it that I'm using, is based in part on each of 3 previously tested forms of interpersonal therapy. One of them is called relationship enhancement. that was developed and is offered to us as consumers of theory by a man named Gurney. And there actually is a marital therapy modality called relationship enhancement marital therapy, which is actually wonderful stuff if you ever want to study it. That right there had the best evidence basis for effectiveness of any of the forms of relationship enhancement therapies that I discovered. I also drew, to some extent, from the work of Greenberg and Greenberg on the topic of emotionally focused therapy. And it basically is getting people to self-disclose and come to understand one another better. And so it's emotionally focused therapy and also emotionally focused couples therapy, written by Greenberg. There were two Greenbergs. And then also cognitive self-disclosure. And this methodology was offered to us by a man named Waring. And so that also is a thing that's done in pairs, in dyads, to help people who are in emotional teams learn to understand each other and respect each other's emotional needs. So I drew ideas from each of these and incorporated them into my treatment model that was called guided dialogue. Okay, so let's take a look then at the logic of single system designs. So rather than being based on the mathematical logic of statistical significance, the persuasive power of single system designs is based on an idea called the principle of unlikely successive coincidences. So let's just say that I have three people. Here are my three people. I'm sorry, I'm picking on people again. Here are my three people. And I'm going to be your therapist. I'm sorry, but you're deeply depressed. I'm picking on you. I know it isn't true. And so I'm going to treat you with cognitive therapy. And so here is a graph of what happened after I provided cognitive therapy for you. You began here, and your depression was at a high level. And then and this marks the point in time when I begin to treat you. That's when we start our counseling. Now, thereafter, your depression goes like this. Does it look as if my treatment helped you? It looks that way, doesn't it? But a lot of things could have happened. Right there, you could have won the lottery. So you could just be a lot more happy person. And the fact that we're talking about what used to be might be completely beside the point. But let's just say that I'm now going to engage another person in cognitive therapy. And so I do. And that person's graph looks like this. Whoops, I didn't connect the dots, but you see what I mean. Now, let's just say that this looks as if it's the same moment in time, but it's actually not. When I started this person in therapy was September, and when I started this person in therapy was in December. So the time is offset. But the same thing happened. The person, again, had a reduction, a fairly significant looking reduction in the level of their therapy. It could be that this was a coincidence, that this person began to get better right when I started the therapy. But if I do it again and the same thing happens, now does it still look like a coincidence? Not so much, because it happened again. If I keep doing that, and every time I do it, the graph looks the same, what are the odds that it wasn't my therapy that caused that result? Every time the same thing happens, I apply the principle of unlikely successive coincidences again, and I see that the chances that it didn't have anything to do with the therapy are vanishingly small. Now, the more number of times I do that, it's called a replication series. So the predictive power that supports my claim that it's my therapy that's helping and not random chance is not provable by mathematics, but just from the pure point of view of logic and common sense. You know, what else could it be? It's looking like if I do this 10 times in a row and all 10 times the same result happens, it's looking like there is something behind the therapy. Whereas if I did a group design and I had 100 people in treatment and 100 people on a wait list, and I do the math and I calculate out and I come up with a p-value. You remember what p looks like in your Research 1 class. P is essentially, in effect, what the p-value is. If p is 0.05, in effect, what that tells you is that there's 5 chances out of 100 that that result could possibly have happened by chance alone. 95 times out of 100, if I did the exact same study, it would turn out the same way. So 95% of the odds favor that it was my intervention that made the difference. Those are pretty good odds. Here I can't calculate the odds. All I can do is apply the principle of unlikely successive coincidences and see if you buy it. Now, if I did 10 therapy cases and they all turned out that at the point in time when I started the intervention, they began getting better. And I said to you, hey, I think the therapy that I'm doing with my depression cases is making a difference. Here are my 10 graphs. Would you buy that? Yeah, most people would. So then that becomes the persuasive power. We don't have the math behind it, but we have pure common sense behind it. The other thing about it is, let's just say, this is a thing that happened to me once, more than once, but I'm thinking of once in particular. Let's just say I have a depressed patient, and here's their baseline. This is the interval of time before I begin my treatment. And I'm measuring depression, and at week 4, my graph is looking like that. There's no movement. I'm thinking, somehow or another, the way that I'm therapizing this person is not meeting their needs. I need to change something. I need to change something about my level of engagement. I need to change something about the modality that I'm using. I'm not meeting this person's needs. Okay, so that's called the response-guided nature. That if I see, as the study goes along, that I'm not getting the result that I want, I can change it before it's too late. Whereas, let's say I was doing the 100 people group design, I can't do the math until I get to the end of the whole thing. And then if it turns out that there was no statistical difference, I basically have, been unhelpful to 100 people and taken up the time of all the 100 people that are in my control wait list. And I can't change that. I can't do anything about it. But if I'm utilizing the response-guided nature of the single system methodology, then if I see, as the results come into me, and I'm graphing them as I go along, that I'm not getting what I want, I can make changes. So for our purposes as practitioners who are measuring the results of our own practice, this is very useful to know. How am I doing? Do I need to make a mid-course correction of some kind in the treatment to make a difference? So that's what's meant by the response-guided nature of the methodology. That's one of the great features of it for our purposes in our own private practice. Okay, so now we have the research design in this particular instance. So what I'm going to do, I've got 6 cases, 6 depressed women, and 3 of them, I'm only going to offer to them standard cognitive therapy. I've got a baseline, and then I've got the start of an interventive phase, just like this. That's the point when the intervention starts. Here's the baseline. Then I'm going to start the intervention and measure what happens through a repeated time series of measurements. So this phase is called, it's designated by the letter A. And that means, how was the person doing in the absence of an intervention? That's the baseline phase. How were they doing before the intervention began? And the B phase is the phase of my involvement with the person that marks the start of the intervention. So 3 of my 6 cases, that's what I'm going to do. And then I'm going to take repeated measures of depression, intimacy, self-esteem, and general well-being, these variables having emerged as possibly significant from my lit review. Now, each case of cognitive therapy alone, that right there is an N of 1 study. 3 of those, one under the other, that's a replication series. So this allows me to replicate my results and see whether or not my type of treatment, the way that I understand cognitive therapy and the way that I apply it, is making a difference in the lives of these 3 participants. My other group are going to be people that I'm going to offer a treatment plan where this is the A phase, that's the baseline. And then I'm going to have a phase of B where I'm going to start them in cognitive therapy, which is the same as what the B was over here. And then I'm going to start them in another phase when they're going to have the combined version of the therapy, the guided dialogue alternating with the cognitive therapy. And then I'm going to wrap up with a return to cognitive therapy alone. So their therapy is going to be divided in phases. That's the A, that's baseline. B is cognitive therapy. BC is the 2 kinds of treatment rolled in together. And then I'm going to wrap up the case with a return to seeing the patient only by herself with more cognitive therapy. Okay? And I'm going to do that 3 times also. So that then becomes a replication series for that treatment method. And then I'm going to take a look at whether this replication series or that replication series results in a preferable outcome. And this will allow me to test whether my combined treatment is any better than cognitive therapy alone. Does that make sense? Okay. So the 3 cognitive therapy cases considered together form a replication series for that treatment model. The 3 guided dialogue cases form another replication series. Contrasting the 2 permits analysis of the differential effects of the 2. So the measures that I'm going to use are, for depression, I'm going to use the Beck Depression Inventory. Perhaps the most well-researched depression measure in the world. The psychometric properties, in other words, the mathematical testing properties of the Beck Depression Inventory have been so thoroughly documented that it's absolutely reliable, that if you use the Beck Depression Inventory, you know how it operates and functions as a tool. You know the extent to which you can trust it. And one of the reasons for the power of that particular measure of depression is that it has questions in it that exactly test each of the 9 symptoms of major depression. So it allows you to capture whether symptomatic improvement on each of those 9 variables is occurring. It's also only got 21 questions on it, so it is not burdensome for the patient to keep taking it, to give you their results time and again as the treatment evolves. My intimacy measure is called the Miller Social Inventory Scale. And as a doctoral student, I had quite a little trouble coming up with a measurement strategy for intimacy because most measurements for intimacy, psychosocial measurements for intimacy, don't separate out whether the intimacy between a couple is all emotional, or whether it's partly emotional and partly physical, whether their intimacy means, that they have essentially an intimate relationship which is working for them. So in the end, I had to modify the Miller Social Inventory Scale and strip out all the questions that had to do with physicality and only leave the questions in there that had to do with emotional intimacy. So if you find a measure that is fairly valid for the thing that you're trying to measure, but not quite, you can modify it. You then modify what the documented psychometric properties of that particular measure are. So it takes you into somewhat unknown territory, but that's better because you at least have hand-tailored the instrument to your own research needs. And that's defensible to do that when you're planning to do single system designs in your own practice. And then for self-esteem, I utilized the Rosenberg self-esteem scale. And then for well-being, I utilized an instrument. These are all paper and pencil questionnaire type rapid assessment instruments. I utilized a measure that's called the General Well-Being Scale. So what did I get? Well, results. This is kind of how it came out in the end. This whole thing took the better part of half a year. I was doing this work on my own, on people in my own caseload in an outpatient setting. So those are the results for well-being. Now this right here is the combined group. So what we have here is, I'm going to use this thing. This is one of my props. It's a walking stick, but it's also a yardstick. Who knew there was such a thing? But anyway, right here it says case number 1. So that's one person. So each line that's got a little square on it, those are the results for one of my individual people. But in order to be able to perceive the overall pattern, I collapsed all 3 cases onto one graph. So there's case number 1. There it is right there. There's case number 2, who's the little diamond person. Case number 3 is the little triangle person. So well-being now. This is the baseline right here. That's where they were in well-being. This is a situation where a higher score is better. So these people had some degree of challenges in their well-being, their general well-being at the start of treatment. This is where they got to as a result of cognitive therapy alone during the B phase here. There was one measurement taken, and for the most part, it didn't change very much at all. There wasn't a whole lot of movement that early on. When it got into the combined treatment of cognitive therapy combined with guided dialogue, now we see some movement. This person didn't really thrive that much. But for the most part, if we kind of took an average, just a kind of intuitive gut feeling, and how you sometimes do that is to take a straight thing like this and lay it over top of the graph and try to kind of calculate what the average slope is. It isn't terribly specific, but you can kind of do that. The average slope of this and this clearly looks like that. But if we reduced it a little bit to take into account this one, we'd have to make it more like that. So there's change in the right direction. And then when they're doing the cognitive therapy alone, they're improving. And the average change there probably looks something like that. So we apply the eyeball technique to it. Now, looking at that and applying the eyeball technique, would you say that change happened? Did the change happen in the right direction? Okay. So the treatment, the combined treatment, seems to have made a difference in the people's general sense of well-being in their lives. Now, those are the results for the combined. These are the results for the cognitive therapy alone. Let me go backwards and forwards. would you say that there's probably very much difference? Not really. It looks as if the slope, the kind of intuitively, I mean, you actually can do mathematical calculations. There are ways to do mathematical calculations using single system design. Fortunately for me, I was not required to do that to get my doctorate, so I felt blessed. But anyway, looking at the difference between this and this, I would tend to think that here, these are in the range of 60 to 70 points on that scale. These results are in the range of 60, 70. That's one outlier. It's a little bit higher. But it looks as if the average amount of gain was pretty much exactly comparable. No significant differences between the two forms of treatment. Does that sound plausible to make that conclusion? Okay. So let's take a look then at self-esteem. Now, the Rosenberg self-esteem scale, it's called the self-esteem scale. But what it actually is, it's the low self-esteem scale. So a higher score is actually worse. Whereas if you see a little bit of downward momentum on the scores in the Rosenberg self-esteem scale, it means the person has less worse self-esteem. And so there's a little bit of a trend here. A little bit. You would say the average of that might be, in through there. A little bit of gain, per se, in core self-worth in something like half a year of outpatient treatment. Not much. The extent to which self-esteem improved as depression changed is not really terribly robust. Okay, so what was it then for the cognitive therapy only group? Not much different. This is also a little bit of improvement for the better. This one was the worst. This went from 30 to 25. These two ladies bounced around from the range of perhaps 27 or so to perhaps 20, what would you say, maybe 23. A couple of points of reduction in problems with self-esteem. Not much. Essentially pretty much comparable to the other group. No difference there. Here's depression. Whoa, now we see some slope. These ladies did good in depression. They started up here. In general, the cutting score for the Beck Depression Inventory, depending on who's talking about it, whose clinical judgment you want to use, is that in the range of 40, it would be warranted to hospitalize a person with a Beck Depression Inventory score of 40. Now, these ladies were not hospitalized, but they were depressed. And then once it gets under about 13, it's considered that they pretty much have entered into remission. And so these are the combined people. And the extent and the pattern in which their depression improved, is pretty consistent, and it looks about like that. The average slope, I would say, looks something like that. And so they did well in therapy in general. They recovered quite nicely. This person's score is right about 13. These two people are well under 13. So it's perfectly defensible for them to be graduated from treatment because their depression is now in remission. So the combined treatment did well. These are the cognitive therapy only people. And the slope there looks really quite comparable. Pretty much the same, if it were a roof, the pitch would be pretty much the same, put it that way. This person is this person is down around 8. This person is well under 13, and this person is about 15. So they also have improved quite considerably. dramatic clinical significance there. But is there really any difference between that and that? Not really. So far, we haven't seen any differences at all in our two forms of treatment. But let's take a look at intimacy. That's the combined treatment. That is actually the steepest slope of any of these graphs. You know, if that were the slope or the pitch of a roof, you'd be falling off, you know. So the average slope there is way steep. So these people have made major gains in the perception, the measurable perception and feeling that they have that there's now emotional intimacy present in their lives. These people are no longer depressed, but they don't have the perception that the emotional intimacy of their lives is any better. Now, having emotional intimacy in your life is the single biggest predictor of whether or not, if you make gains in depression, whether or not you're going to relapse. So my conclusion from doing this study is that all things being equal, the results are the same if you work with the significant other or you don't, except that you're going to end up with a person who is no longer depressed but has made tremendous gains in emotional intimacy and is therefore at significantly less risk for recurrent repetitions of episodes of depressive illness. Okay? Does that make sense? Do you buy that? Okay. So we then look at the implications of that. That depression responds well to outpatient treatment. Well, the field kind of already knew that. This is a thing that was known to our field. As depression lifts, general well-being improved modestly. Self-esteem does not improve in brief treatment to a measurable extent. Not to say that it's never going to improve, but you're not really likely to see, or I was not likely to see, improvement in core self-worth in that brief an interval. Now, I think personally that self-esteem rises with experiences of success in life. And that's a thing that you have to work with a person to try to help them to understand how are you going to gain experiences of success in your life even past the interval when you're no longer in treatment. And so that's part of the reason that I personally am not that sold on self-esteem being a thing that you can accomplish through filling out affirmations, or that it's going to change that rapidly at the core, at the person's fundamental core self-understanding. It doesn't change that quickly, and it doesn't change by, kind of gimmicky stuff, worksheets and stuff like that. Anyway, alleviating depression alone does not necessarily improve emotional intimacy. Response-guided nature of single-system research lends itself to a preliminary test of a novel form of treatment. So if I wanted to then write to NIMH and try to get them to fund a group design study where I could take these 6 cases and generalize them to 100 cases, I at least now have these 6 cases to underscore, my claim that that would be a worthy thing to do. Preliminary data is crucial to secure funding for a larger scale study. And a single clinician can monitor his or her own practice. I did all of that in a community mental health center in the state of South Carolina by monitoring the results of my own practice. That's a lot of information to derive from 6 cases. It's not proven information, but it is highly suggestive. And thereafter, if I could ever possibly avoid it, thereafter I would never try to treat a woman for major depression without attempting to include her primary significant other. Because to me, that evidence is so strong that it's just better to do that. And sometimes they won't cooperate, you know. But if I had my druthers about it, if I went back into practice, I would never try to treat a case of major depression in isolation, because it seems to me from that so clear that it's better to do it the other way. 6 cases and just dots on a graph. That's a lot of information to derive from something that I was able to do while working for a living in a community mental health center. So, hence my sales pitch to you all that personal practice assessment is way, way interesting to do, and that it's way, way worth doing, because look at the wealth of information that you can derive. The people I was working for didn't even have any idea that I was doing this. I just did it on my own. Now, if I were still in practice, I wouldn't do the general well-being measure. And I wouldn't do the self-esteem measure, and I probably wouldn't do the intimacy measure. I probably would just stick with the intimacy measure and the depression measure, because that's where the change was the most important, and those are the 2 variables that have the most to do with overall a successful outcome. So I would ditch the other 2 testing and measurement protocols and just stick with those 2. But would I keep doing it? Oh yeah. Why? Partly because, okay, take me out back and shoot me. I'm a nerd, but it's fun. It's extremely validating and liberating to be able to monitor your own practice, see the graph going in the right direction, and now you have evidence of your own effectiveness that you're not having to simply based on gut or intuition. You know, you've got some numbers to back you up. So, end of sales pitch. Also, end of presentation. Thank you all for the invitation.